Hello and welcome to this webinar addressing the TB screening, prevention and treatment needs of people living with HIV in the era of COVID-19. I'm Dr. Anton Pozniak. I'm the immediate past president of the IAS and a physician at the Chelsea and Westminster Hospital in the HIV unit and honorary professor at the London School of Hygiene and Tropical Medicine in research. So our aim of this webinar is to provide a summary of the latest evidence and science around tuberculosis for people living with or vulnerable to HIV and TB infection. And we're going to get this from the Conference on Retroviruses and Opportunistic Infections, fondly known as CROI, which took place in March 2021. We're going to highlight the science, tools, guidance from implementers, global donors and normative agencies. The webinar will provide an opportunity to amplify the voices and perspectives of civil society representatives on TB and HIV services that respond to people's health needs and preferences and showcase TB and HIV service delivery approaches that are truly person-centered. So now, housekeeping rules. First of all, please note that due to the number of attendees, all participants are muted, but feel free to send your questions to the speakers at any time through our Q&A box. You'll also notice there's a thumbs up symbol when somebody will ask a question in the Q&A box. And if you have a similar question or find that question important, please click on the thumbs up sign to help us prioritize the questions. In case you're having any issues with Zoom, you can get additional guidance provided in the chat box, and you can also send us technical questions that you might have. We've planned time after the debate for the Q&A, so please send your questions there, focusing on today's topics. And if your question is for a specific debater, please indicate their name when typing your question. So I'd now like to introduce my co-moderator, Kenelwe Lynette Mabote. She's been a TB advocate for over a decade, working in Africa, Latin America and Southeast Asia. She's a legal background with a degree in intellectual property. Lynette lives and breathes community engagement and grassroots advocacy and strengthening, and is currently a part-time consultant and global advocacy advisor for the Treatment Action Group, TAG. Thank you so much, Lynette.
Good afternoon, everyone. Thank you very much for those amazing remarks on top. We are now going through a wonderful cascade of speakers. We've got 6 exciting speakers for today, and I think we should just get right into it. Our first speaker, Pozniak, who will be giving us TB Science 2021 conference. Over to you, Dr. Pozniak.
Thank you, Lynette, for that introduction. And now on to the latest TB science from CROI 2021. Here are my disclosures. I'm going to talk a little bit about short course TB therapy, about high dose rifampicin in TB meningitis, and also the effect of high dose rifampicin on antiretrovirals, a little bit about the interaction for rifapentine used in latent TB and antiretrovirals, and then finish with some contact tracing data and targeted TB testing. The first thing was, can we really make TB treatment easier? As it's complicated, it can take 6 months for standard therapy, and there have been failed attempts to reduce this time down from 6 months to 4 months in the past. But recently, with study 31, using high-dose rifapentine and moxifloxacin, we've had some success. But does this strategy, this new strategy, work in HIV-TB? Here's a resume of study 31, the control arm at the top here using the standard 4 drugs for 8 weeks, and then followed on out to 6 months with just 2 drugs of isoniazid and rifampicin. And the second arm, you can see here that they use short course at now 4 months, 2 of the 4 drugs and then 2 of 2 drugs. But instead of using rifampicin, they used rifapentine. And in this investigational arm with moxifloxacin, they used 2 drugs of isoniazid, rifapentine, moxifloxacin, and then reduced this down to 2 months of just 3 drugs of isoniazid, rifapentine, and moxifloxacin. Here's the study population. You can see 2,500 were actually randomized, of which about 8% were HIV positive, with a median CD4 of 344, well divided between the 3 arms. Now let's have a look at the efficacy in the HIV population, and there are 3 ways to look at the efficacy in this protocol: microbiology eligible, assessable, but by the protocol. And if we look at by the protocol here, you can see that there's very little difference between the control, the standard therapy, and this new therapy of rifapentine, moxifloxacin. The rifapentine arm didn't do quite as well, and in fact the rifapentine arm without moxifloxacin, you can see, was quite poor amongst all 3 ways of doing the analysis, whereas when you had rifapentine and moxifloxacin, it was non-inferior to the controls. When we look at safety outcomes, you can see the rifapentine, moxifloxacin was relatively safe, and in fact there were less grade 3 to 5 adverse events compared with control. So it's really good news. We have a 4-month rifapentine moxifloxacin combination, which we can now use in HIV, and it's a major milestone in TB treatment, reducing the time of therapy down from 6 months to 4 months. There's also been some final data from the NICS study looking at use of 3 drugs in MDR, XDR, TB, pretomanid, bedaquiline, and linezolid, which is all taken orally. And you can see here from the results that out of 109 participants, of which half were HIV positive, actually, when you look out all the way out to 24 months, you can see that 88% of them, by intent to treat, were sustained in terms of their recovery from MDR, XDR, TB. So that's fantastic news for both drug-sensitive and drug-resistant tuberculosis. Now, one of the problems with Tb meningitis is that in the CNS you get very low concentrations, and people believe that this may have a negative impact on the outcomes. And so can we increase the dose of rifampicin to try and get it more into the brain? And there are some data suggesting links between dose and survival. And in pulmonary TB, high dose rifampicin reduces the time to culture conversion in sputum. Here's the study design, 3 arms, the control arm here, standard of care. Here's one now with high dose rifampicin instead of 10 milligrams per kilogram, 35. And then a third arm giving 20 milligrams intravenous for 2 weeks. And the reason for this, if you're unconscious, of course, intravenous would be essential because it would be difficult to give oral drugs. And they, at week 8, they switched them back over to standard treatment to complete. So what did we see in the CSF? You can see here from the graph that here's the line, this straight line here, that you want patients to get their concentrations above. Almost everybody in the intravenous and oral did so, but in the controls, very few did so. And it really shows here. If you look at the area under the curve, you can see it's 0.27 for controls, 10 times more for the oral, and about 8 times more for the intravenous. So it really looks good that we can get more drug into the CNS. But in terms of clinical outcomes, we didn't see any difference, but there were only 60 patients in this, so it wasn't powered to look at that. But the major thing is there was no excess toxicity, and they are moving forward now for a large clinical trial to look at its utility. So high dose rifampicin in TBM. But these high-dose drugs may have an effect on our antiretrovirals. And there's a study here looking at both ephedrins and dolutegravir. And you can see from the ephedrins, the number of people that were given high-dose rifampicin and got a low level of rifampicin was just 1 out of 15. And the number of people who were given standard dose of rifampicin and ephedrins, the number of people at a low level was 1 out of 19. So it's very similar. It had very little effect on the efavirenz levels. In the dolutegravir, which is widespread use now in resource limited countries, you can see here that with 10 milligrams of rifampicin, only one had a low level, but 4 did when you give high concentrations of rifampicin. Now, you'd think this might be concerning, but actually when you looked at those with viral suppression, there was no difference at all. So it didn't have an impact. And it's probably because the threshold level for dolutegravir is relatively low in terms of maintaining the virus undetectable. But we need to have more data now. Now, one of the great things about latent TB is you can treat it for 1 month with rifapentine plus isoniazid. You can see the graph from up here, the red line of isoniazid for 9 months and the blue line of just 1 month of rifapentine isoniazid. You can see overlap. But the issue is, does rifapentine interact with our antiretrovirals? You can see from this box here, the colored box, the databases predict that dolutegravir goes down a bit, but manageable. Raltegravir goes down a bit, but manageable. And but what about bictegravir, which is used a lot in various parts of the world? It predicted it would go down and you shouldn't use it, it's red. Well, here's the proof of this from data where bictegravir concentrations went right down, almost 95% reduction, and actually 2 out of 16 of the patients who were given this combination actually had viral rebound. So it's a no-no, rifapentine and bictegravir. And now, contact tracing. What's the best way of contact tracing? Should you do this? This is from South Africa, just standard of care. Send people letters, do a telephone call at 1 month, or do you do a lot of intensive contact tracing? You go there, you test everyone's sputum, you do tuberculin tests, you do counseling for HIV, you refer people immediately who you find, and you can start isoniazid prevention at home and do month 3 check-in visits, real intense package. Well, interestingly, when you looked at 15-month outcomes, whether you gave just the standard referral letter or did all of this intensive work, actually the numbers of diagnosis of TB and all the people who died from other causes or TB, you can see were identical. Actually, all that effort made very little to this results in a South African setting. And I think people ought to look at this very carefully because resources are precious. Finally, targeted universal testing for TB in clinics. Now, usually if you just do standard testing for tuberculosis in clinics, it's symptom-based and then you get tested. But this group decided they were going to also, as well as doing that, target anyone who's HIV, target those who had a close contact with TB in the last year, and target anyone who had TB in the previous 2 years. And so this is what they did. Here's a standard of care done in 30 primary healthcare facilities. If you've got symptoms of TB, you're checked out for sputum by using the expert method. Now, in these 30 clinics, they did exactly the same, but they added in targeting the HIV, the close contacts, and anyone who had TB in the last 2 years. And what they found was they actually started to get a good yield of patients by doing the targeted testing, 5% in the HIV infected. Now, historically, what was happening, the clinics were diagnosing 8% fewer patients year on under the standard of care. But when they did the targeting, this resulted in a 17% net increase in TB cases diagnosed. So that's fantastic results from this. And again, targeting, using resources cleverly could be really important in our battle against tuberculosis. So in conclusion, we have 4-month treatment for drug-sensitive TB, 6 months we already have for MDR, XDR, but this study today, the next study showed you could use 3 drugs. High-dose rifampicin does improve CNS concentrations, but we need to know the clinical use. But these high-dose rifampicin, although they lower dolutegravir level, it appears it doesn't affect clinical outcome. I'd like to see bigger studies. Rifapentine's a no-no with bictegravir, and then doing standard contact tracing just with letters and a month 1 phone call seems to be as good as using a lot of resources, and targeting TB testing improves yields. And with that, I'd like to thank you very much for listening.
Thank you so much, Anton, for the presentation and breaking complicated science that you get to and community folks. So now that we've done that, with the reason is that we need to find ways to use other mechanisms to ensure that we're getting the highest standard of care. Our next speaker still does not require any much in this space for a very long time. Doctor, presentation. Thank you.
Hello everyone, my name is Sylvain Kutsum from Doctors Without Borders, Médecins Sans Frontières, and I'll be making the case for integrated multi-disease interventions with a special focus on the package of care for advanced HIV disease. I don't really need to make the case because it's been made before in this WHO document in 2017, as well as in the excellent UNITAID report on integrated management of HIV, HCV, TB, and other co-infections. Co-infection is extremely common in the most important infectious diseases of global health importance. We have 7 million people with HIV who do not know their status. We have, out of 10 million new TB cases, 820,000 who are co-infected with HIV. People with advanced HIV very often have TB, cryptococcal meningitis, and or severe bacterial, fungal, and viral infections, and then malaria and HIV together cause up to 2 million deaths annually, and malaria is a often underestimated cause of death in people with HIV. 256 million people live with chronic hepatitis B, only 9% actually know their status, and out of the 71 million people with chronic hepatitis C, 2.3 million also have HIV. And then last but not least, antimicrobial resistance is increasing dramatically, with an estimated 700,000 deaths per year at the moment, but expected to increase up to 10 million deaths annually by 2050. And at the moment, very little is known on the levels of antimicrobial resistance in people living with HIV. One of the major reasons why these diseases, infectious diseases, remain underdiagnosed is because of limited access to diagnostics. And whilst we've made great progress for TB, for most of the other diseases mentioned, we're still lagging behind. So now, what about advanced HIV? Test and treat has been promoted as the solution to end AIDS. It is necessary, but it is insufficient. The HIV cascade is actually not a cascade, but a circle. People start treatment and stop treatment, re-enter into care, fail treatment, and re-enter into care. And therefore, we see that diseases associated with advanced disease, such as cryptococcal meningitis, actually do not decrease in incidence, even in countries with high ART coverage, such as South Africa. Today, still 1 in 3 people who start ARVs have advanced disease. And then there's an increasing role, there is an increased role of non-communicable disease. What's the package of care for advanced HIV disease? We start with CD4 count, which is the gateway to the advanced HIV package of care. And for people with a CD4 count below 200, we look for the top 2 killers of people with HIV, ALER, the TB LAMP, urinary LAMP, point of care test, and the CRAG LFA to detect cryptococcal meningitis. And in people with TB symptoms, we use GeneXpert, which is slightly more complex than a point-of-care test, but adequate for bigger health centers or district hospitals. So the 20-tool checklist for diagnosing, treating, and preventing AIDS. That's what I'll be covering now. Rapidly, HIV rapid diagnostic test, early infant diagnosis, nucleic acid amplification test, routine viral load, CD4 cell count, TB rapid molecular diagnostics, the TB LAM, and the CRAG. I encourage you to look at the actual checklist because then you can also look at the treatment and prevention part, which I won't be covering today. So HIV rapid diagnostic tests, nothing new. They've been around for a long time. It's the entry point for testing for HIV, $1 per test. What is new, or not completely new, but still underused, is the availability of oral self-tests and at ever decreasing prices now, $2, which is very useful for populations who are currently underserved or highly stigmatized. Point of care for infant diagnosis. This is newly recommended by WHO since March 2021 as the recommended test to diagnose HIV among infants and children younger than 18 months. Why point of care? Because it reduces turnaround time, because it increases the proportion of infants that start ART within 2 months, and because it's cost effective. Current prices are $20 for the Abbott Larry Q or $14.9 for the Cepheid Expert HIV Qual. The advantage of the Cepheid is that you can do it on the same platform as the TB GeneXpert cartridges and the viral load cartridges. Routine viral load, also a new recommendation. Routine viral load was recommended by WHO since a long time, but now they say that point of care viral load may be used to monitor ART, and there is a new algorithm. So who needs a viral load? Everybody on ARVs at 6 months and at 12 months and then annually, but also, and that's often forgotten, targeted viral load for people with suspected clinical failure or adherence difficulties. Lab-based $10, point of care cartridges with Abbott $20, and the viral load Cepheid at 14.9, which is the integrated platform. For CD4 count, the gateway to advanced HIV, wrongly believed not to be necessary anymore. CD4 is not necessary for monitoring of HIV, but it's needed to identify people at high risk of death from opportunistic infections, and it's the diagnostic test for advanced HIV. So all new initiations on ART, all people returning to care, and all people with signs and symptoms of advanced disease or treatment failure should have a CD4 count. And as I said earlier, there is a new opportunity with the Omega Visitech test, which is a real point of care test that can be done by lay cadres and is available under the Clinton Foundation's early market access vehicle at $4. 5, the GeneXpert test, which is the initial test for all symptomatic patients with TB symptoms, and has the advantage that it also diagnoses drug-resistant TB. 6, the TB LAM, recommended by WHO at all levels of care, including primary health care, all patients who are admitted with HIV to hospital with symptoms or with serious illness, or if asymptomatic, with a CD4 count below 200. And for outpatients who are asymptomatic, should be screened with TB-LAM if they have a CD4 count below 100. All patients who have TB symptoms could have a TB-LAM as well. The TB-LAM is useful because it increases the number of people who are diagnosed with TB, especially disseminated extrapulmonary TB, especially at lower CD4 counts. And just as important is that it dramatically shortens the time to TB from presentation to TB treatment to a couple of hours compared to sometimes several days with other methods. TB-LAM costs $3.5 per test. And then lastly, the CRAG LFA recommended by WHO for all people with a CD4 count below 100 or below, well, or actually we say below 200, regardless of symptoms, and anyone who has symptoms of meningitis. There are two tests available, the IMI at $2 and the Biosinex at 2.4. And then there are additional diagnostics that can be useful depending on the local epidemiology. You know, glucose as the entry diagnostic test for diabetes, malaria in high malaria areas, gram stain, blood cultures should increasingly be used to diagnose septicemia and antimicrobial resistance. And then depending on epidemiology and population, hepatitis B rapid test, hepatitis C rapid test, potentially expert viral load, expert Ebola for Ebola, and expert HPV if resources allow. One but last slide, who to test. I've covered that, where to test, and that's important. At community level, HIV testing can be done. At primary healthcare, we should at least have point of care CD4, urinary TB-LAM, CRAG, rapid HIV test, and where there is a mini lab, viral load, MTB, gene expert type tests, molecular diagnostics, and early infant diagnosis. This can be done, most of this can be done by lay cadres, at least all the rapid tests. It's been shown in multiple studies that lay cadres, if they are properly supervised and there is quality control, can operate these tests effectively. At the secondary level, we have the same tests, plus we should have molecular diagnostics, viral load, and if possible, blood cultures for sepsis. And then at tertiary level, we can add a couple of tests, but I won't cover that. So in conclusion, co-infections of major infectious diseases are common, especially in people living with HIV. The basic package of care for HIV should include HIV rapid test, early infant diagnosis with NAT, point of care for all infants and children less than 18 months, HIV viral load for routine monitoring and for detection of treatment failure, CD4 count for all new initiations and re-entries in people with suspected advanced HIV, TB-LAM and CRAG for people with CD4 below 200, and rapid molecular diagnostics for MTB-RIF. Point of care is often preferable due to shorter turnaround times. Most point of cares can successfully be task shifted to late cadres, and then we still need new tests for neglected causes of HIV mortality, PCP, toxoplasmosis, easier tests to detect severe bacterial infections and antibiotic resistance, test for CMV, herpes, resistance to dolutegravir. Thank you very much. For more information or references, you can click on the following links.
Thank you very much for those inspiring sentiments Gilles. I definitely am a bit concerned that we're looking at a 1 in 3 persons actually having advanced HIV disease. We really need to do better. And I think we are a bit nervous about the COVID-19 epidemic. So that we don't actually waste a lot of time, we've got our next speaker. Our third speaker is Mr. James Mala, who is the CRG, Community Rights and Gender Advisor at Stop TB Partnership. James works with country as well as community support in the impact team, where he supports work on human rights, gender, and community engagement for the Stop TB Partnership. Please proceed, James, with your presentation on the HL and the UN political declaration to fight against tuberculosis. Thank you.
Good afternoon, everyone. Thank you very much to the IAS for inviting the Stop TB Partnership to join in this very important discussion today. During the next few minutes, I'd like to talk a little bit around tuberculosis, COVID-19, and the deadly divide, TB commitments versus TB realities, which is a TB affected community progress report looking at progress against the UN high-level meeting on TB, targets and commitments. So just to set the scene, and I know many of us would be very aware of these numbers and statistics, but it's important to note that TB is the leading cause of death from a single infectious disease. As many of you would also know, about 1/3 of deaths among people living with HIV are from TB. 10 million people develop TB every year, and 1.5 million of those die. And 1.4 million, which is nearly 1.4 people, which is nearly 2 billion worldwide, carry the latent TB infection. In the context of COVID-19, it's interesting to sort of look at the comparison with TB, and one of the things that we can observe is the significant overlap in locations where both TB and COVID have been a significant challenge. One of the things that's interesting to consider here is also both the common manifestations and the common responses of both TB and COVID-19. And it's something that can also help to inform opportunities for integration and for health system strengthening going forward. In addition, noting the significant opportunities in investment around COVID-19, that integration can hopefully scale up. And there's several examples of the ways in which we could integrate on this slide. In particular, there's 3 main areas that we could be thinking a little bit more about in terms of interventions for prevention and care of airborne respiratory infections. These include implementing massive community and primary healthcare level screening, to implement airborne infection prevention and control measures in all healthcare units and in congregation settings, and to implement real-time surveillance data with early warning systems and data-driven and agile public health decision-making. One of the areas that's been interesting, particularly in this last point, has been around community-led monitoring and the opportunities and the value that this real-time data can provide to inform national health responses. So in the context of TB more broadly, we can see from 2015 to 2019 that there's been a significant decline around the number of missing people affected by TB. However, we can also see in the context just of India, the impact on notifications around TB once that the COVID lockdowns were declared in the country. And you can see from the graph the significant dip that has taken. Almost a 70% decline between weeks number 10 and 15 in the course of the lockdown. So what the implications that this has had in terms of the TB response and in achieving the UN high-level meeting targets and commitments is significant. So between 2020 and 2025, it's predicted that there'll be an additional 6.3 million people developing TB. An additional 1.4 million people will die from TB, and the setback of at least 5 to 8 years in the fight against TB. And in looking at notifications and more recent data, it could even be significantly more extensive than this. We know as well from communities on the ground that this impact has been extensive with a range of different impacts, everything from funding to the resources available in terms of human resources, social support systems, and a significant impact across the full cascade of care in the TB, in national TB responses. So we've also seen that there's been a range of other impacts of COVID-19 on TB, and this has been more nuanced in the context of drug-resistant TB and TB preventative therapy. There has also been some studies and data that has come in which has shown the increased mortality in people with both TB and COVID-19, and that's reported in Kerala and also in South Africa. There has also been an impact around COVID and TB enabling environments in issues such as stigma and discrimination, mental health support, and human rights and gender-related barriers. Some of these barriers are new in the context of the pandemic, but there has also been the exacerbation of a number of existing barriers, and stigma and discrimination is one such example. A fourth area is definitely looking at some of the social determinants of health. And we know that COVID-19 is also contributing to some of the drivers of TB, including through undernutrition and poverty. So in 2020, we know that at a global level, COVID-19 replaced TB as the most common cause of death from a single infectious disease. However, in Global Fund eligible countries, TB deaths continue to exceed COVID-19 deaths. And I draw your attention to the COVID-19 information note, which is shown on the screen, which provides some guidance for countries in terms of catch-up plans to mitigate the impact of COVID-19. And that's an important resource that's available for the high-burden TB country context heading into Global Fund grants and catch-up plan development. So we know, and this is an article that was recently released by the Executive Director of Stop TB and the Minister of Health from India, who is the new chair of the Stop TB board, just to really call for the fact that the fight against TB has been paused by COVID-19, but it must resume. And this high-level political leadership is going to be critical, not just in India, but across all high-burden TB countries. So as part of this approach to building back better, it's going to be important to sort of have interventions to address COVID, TB, and future airborne pandemics as well. This can integrate screening and testing. It can integrate tracing, surveillance, and models of care, and also investment in community health systems. And I mentioned community-led monitoring and community networks for advocacy, human rights, and gender-related barriers and social protection systems and mental health support as well. I just wanted to bring attention to those because a lot of the focus has been on some of the screening and testing, and they're of critical importance as well. Opportunities for bidirectional testing and integrated screening offer a significant opportunity to really impact people affected by TB despite the challenges of the COVID-19 pandemic. So I note that in the context of TB and accountability, in 2020, there were 2 progress reports that were developed. The first was developed by the UNSG, and in that report, there was a commitment to ensure that TB prevention and care are safeguarded in the context of COVID-19. In addition, there's a report called The Deadly Divide, TB Commitments versus TB Realities, which is led by the global TB community, which goes for the ambitious target of leveraging COVID-19 as a strategic opportunity to end TB. The community report provides a voice for those most affected by TB. It provides a progress report of the pivotal role that communities can play in following up and monitoring the declaration and its commitments. It is part of the global community's accountability process now and in coming years. It complements the 2020 UNSG progress report. And it's a status update on the Declaration's targets and commitments through the lens of affected communities and civil society. As this slide shows, it's the product of extensive community engagement and participation and leadership, the likes of which we haven't seen previously in the context of TB. And as you can see, that there is 6 areas or 6 calls to action, which is like the structure of the report, focusing on the 5 key asks that were taken to the UN high-level meeting. And as was mentioned on a previous slide, there's a key focus around leveraging COVID-19 as a strategic opportunity to end TB. And there's a number of key messages that have come out of this report. And whilst there's clearly been advances by governments and member states in all areas of action, there is still a significant way to go. And we know that the current deadly divide between commitments and results is hitting hardest those most key and vulnerable populations. There is a critical role around the engagement and funding of TB affected communities. Community rights and gender will play a critical role going forward. And while an accountability for the response for TB remains an area that requires further attention and prioritization. Funding for TB remains one of the biggest challenges, alongside enhancing the necessary political will. And whilst COVID-19 has disrupted everything, it is also an opportunity in TB to build everything back better. You can find references to the reports at the links on this particular slide should you wish to read further. So my concluding remarks is that there's been a profound impact of COVID-19 pandemic on the TB response. And as I said, progress has rolled back 5 to 12 years. Financing and political commitment and communities are needed for the recovery process. We must learn to build systems for the world to defend against airborne infections, including TB, COVID-19, and any future pandemics. And in this context, the 6 calls to action from the deadly divide, TB commitments versus TB realities, has never been more important. At the 2021 UN high-level meeting on HIV/AIDS, it would be critically important to ensure that those calls to action and those priorities are also represented in the political declaration. Thank you for your time.
Thank you so much, James, for that powerful presentation and for centralizing the importance of the community in the TB response. I, for one, am wondering whether or not we can actually pause TB services and what has happened since the COVID pandemic. If we're looking at 12 months of disruptions setting us back 8 to 12 years, we're in a lot of trouble. Just to keep the track moving, we now welcome Dr. Cook Tran. Dr. Cook is an epidemiologist at the Division of Global HIV and TB at the CDC in the United States. She's got extensive experience in public health training and working on TB, influenza, on rabies, and Zika, and has worked in numerous countries, including Eswatini and Vietnam. I now call on Dr. Tran to give us her perspective on how we can integrate better and do better in this. Thank you.
Thank you for the introduction and the opportunity to participate in this wonderful webinar. Next slide, please. In 2017, PEPFAR set a target to provide 1 course of TPT to 15.5 million PLHIV. Since then, over 5 million have completed 1 course of TPT, which is 36% of our target. This is observed in the green bars in the figure on the right. COP guidance states that TB services should be fully integrated to ensure TB treatment are optimized and harmonized, which includes DSD models. Based on 6 months of data from FY20, Q3, and Q4, we're only providing 67,000 PLHIV with TB treatment. This is 20% of the estimated number of TB cases in our PEPFAR-supported countries. This is observed in the orange bar in the figure. Based on our current performance, it is clear that we cannot reach our targets unless we continue to adapt TB services to existing DSD models for HIV care. Next slide, please. Recognizing the need for TB treatment integration, we developed a DSD guidance document to help countries think through this integration following IAS's when, where, who, and what. To help you contextualize the integration of TB treatment within DSD models, I will walk you through an example with visuals from the guidance document. Next slide, please. This figure is the ART track of a client on 3-MMD. This track consists of a clinic visit every 6 months and medications fast-tracked for pickup every 3 months. Next slide, please. With planning, it is possible to integrate TB treatment into 3-MMD model. Here we propose a client to come back to the clinic at month 2 for TB assessment. This is the only time the client will have to break their model if they're responding well to treatment. In conjunction with the clinic visits, medication and program engagement will be overlaid during the 6-month TB treatment course. Next slide, please. To make it more digestible, I'll break down the TB treatment into 3 phases, which is in the previous slide. Phase 1, the intensive phase, consists of 2 visits with the clinician. The first visit is to diagnose and initiate the client on treatment. About 2 months of medication is dispensed at this visit. The second visit is to conduct an assessment to ensure the client is responding to treatment. During this period, program engagement with the clients occur at least weekly to monitor for adherence and adverse events and to provide counseling. Phase 2, the continuation phase, occurs after the provider evaluates the client's treatment response at visit 2. In this phase, clients are dispensed 4 months of treatment. The program engages at least monthly to monitor clients for adherence and adverse events and to provide additional counseling. Phase 3 is the completion phase. This phase consists of the 3rd and final clinic visit. This visit assesses for effectiveness of treatment. I would like to note that clients may stay in the different phases for a longer period of time or may have different needs. For the next set of presentation, I'll briefly provide considerations of the different phases of TB treatment. Next slide, please. Because expansion of DSD models may mean less frequent facility-based interactions, high-quality screening for TB disease should be conducted regularly in other settings or virtually. TB symptom screening and evaluation could be incorporated into COVID-19 screening and testing occurring in or outside health facilities. Screening can also be provided during standardized virtual follow-ups, during community drug distribution, by treatment supporters, or by clients themselves. Sputum sample collection could be carried out at the time of screening positive or shortly after. Sample collection can be done in the community setting to increase patient convenience by utilizing networks of lay providers, such as peer educators, community health workers, and leveraging existing referral and transport systems for HIV viral load or COVID-19 testing. Next slide, please. We believe TB diagnosis is complicated and should be done by a provider at the initial clinic visit. Client education and counseling could be first done by a provider or trained public health official, and later reinforced by a treatment supporter such as a community healthcare volunteer or peer educator. If drug supply permits, we recommend longer TB treatment dispensing intervals to ensure uninterrupted treatment. If possible, we recommend a 2-month supply, which is enough medication until their second clinic visit when they're evaluated for TB treatment effectiveness. Next slide, please. After the client's initial clinic visit, it is important that their peer educator or community worker engages with the client at least weekly to monitor adherence and adverse events, and to also reinforce client education and counseling. This can be done in the community, in person, or using digital technologies such as phone calls or SMS. At each interaction, the treatment supporter should record and report any serious findings to the provider. Next slide, please. About 2 months after the client's TB diagnosis, a TB assessment for treatment effectiveness is needed. This TB assessment will need to be conducted at the clinic by the provider. The provider, again, will continue to educate and counsel the client. Note that sample collection and testing should be completed prior to this visit. The collection can be done in the community for convenience. Next slide, please. If the client is responding well to the medication, we recommend they receive 4 months of medication, which is enough to finish treatment. Ideally, the medication will be given at the same health center, if not a community distribution point or at the client's home. Again, recording and reporting of this information is critical for patient care. Next slide, please. During the continuation phase, peer educators or community healthcare workers could engage with clients at least monthly to monitor for adherence and adverse events, and to continue to provide education and counseling. They continue to report and record any major findings, such as adverse events or issues with the client's health provider. And if needed, medication can be dispensed during this time if they were given less than 4 months of treatment. Next slide, please. This phase consists of the third and final clinic visit. This final TB assessment will be needed to conduct at the clinic by a provider. At the time of the visit, the provider will determine whether the client is cleared of the disease and provide additional education and counseling to the client. The provider will be responsible for recording the treatment outcomes and reporting the findings to stakeholders. Note that the sample collection and testing should be completed prior to this visit. Next slide. COVID has led to changes in policy and practice, shown in the figure on the right, with many countries explicitly endorsing MMD for TPT and TB services. However, the scale and scope of implementation is unknown. If your country is integrating TB services into DSD models, please share your experiences with us at CDC. With CARES funding, CDC is launching an effort to systematically implement and evaluate TB services in a rigorous and robust way in 8 countries across the PEP4 platform. Each country will receive a funding envelope of $1 million to implement and pilot sites to explore this implementation aspect with 1 or 2 implementing partners. Each country will have a mix of innovations they are testing, but common across all will be DSD/MMD for TPT and TB treatment. We'll be exploring the use of different digital adherence and adverse events monitoring technologies and comparing different models for interim and treatment outcomes. We'll also be developing M&E approaches, which we can hope to supplement the MER indicators. We are in the early stages of protocol development now and hope for implementation later this spring. Next slide, please. This concludes my presentation, and if there's any questions, please feel free to email us. My email is ywj0@cdc.gov. Thank you very much.
Thank you for that amazing presentation, Dr. Cook, on how we can leverage DSD services within the TB response. I know that a lot of civil society organizations, as well as community partners who are part of the PIP for COP process at current point, value that data right now as they're negotiating their country operational plans. We are running out of time, and unfortunately, the party must go on without really introducing our speakers in much detail. Our next speaker is Dr. Andrew Medina Marino, who's a senior investigator and co-lead for the Division of Men's Health at the Desmond Tutu Health Foundation in South Africa. Over to you, Andrew.
Good day to you all. Today I'd like to tell you about some of the work we're doing with men to help improve health and TB-related outcomes. Next slide. In South Africa, TB is the leading cause of death nationwide. In a study from KwaZulu-Natal, TB was found to be responsible for a large portion of the differential life expectancy between men and women, accounting for 81% of the life difference among those with HIV and 43% of the life difference amongst those without HIV. The South African REMOC study found that men were 2.78 times more likely to have adverse outcomes compared to women due to cavitation from previous TB infections. Next slide. Work by our group found that male sex was independently associated with smear non-conversion, which was predictive of treatment default. A host of other studies have reported that men are more likely to be lost to care and die during TB treatment. In 2017, 63% of all microbiologically confirmed cases of TB in South Africa were among men. To visually drive home this point, let me show you some TB incidence curves from South Africa. Next slide. When we look at incidence per 100,000 population stratified by sex and age bands, we see that the incidence amongst men in the blue is significantly higher compared to women in red. Now, please make sure that you take notice of the y-axis, which shows that in a quarter of those age bands, men topped out around 1,000 cases per 100,000 population. I point this out because, next slide, in hard-hit Eastern Cape Province, where we conduct most of our work, the TB incidence in many of these age and sex stratified categories are nearly double those seen at the national level. Furthermore, in many age groups, the incidence of TB among men compared to women is nearly 2 to 3 times higher. Next slide. Of note, in 2018, South Africa conducted its first national TB prevalence survey, which revealed an overall prevalence of 852 cases per 100,000 population, which was much higher than the original WHO estimate of 520 per 100,000 population. Of serious concern, but not unexpected, the prevalence survey confirmed a significant sex disparity in TB incidence. Next slide. Given the global and South African specific gender disparities in TB prevalence, uptake of diagnostic testing, treatment initiation, and outcomes, we sought to identify and implement an intervention that would address and decrease these serious disparities amongst men. Next slide. Our first step was to do a literature review on adherence interventions that we could adapt and or optimize to improve men's TB care and treatment outcomes. An example of a paper that illustrates the difficulty in this approach was this recent meta-analysis by Alpina and colleagues. Next slide. These authors identified 129 papers that reported on the outcomes of TB treatment adherence interventions, none of which were male-centered interventions. We did a deep dive review of the 76 papers published after 2005. Among these, only 17 papers disaggregated their results by sex. Of those papers, 5 reported significantly better outcomes among women, but no effect amongst men compared to the control. 8 interventions showed men did better than the control, but women still experienced better outcomes. And 4 papers reported no improvements for either men or women. At worst, this uneven reporting of sex disaggregated results may perpetuate gender disparities. At best, poor reporting of sex disaggregated results made it difficult to identify TB support interventions or components thereof that could have been adapted or optimized to improve men's TB outcomes, and thus decrease their gender disparities. Next slide. To address the lack of interventions to improve men's TB treatment outcomes, we conducted preliminary work to identify men's preferences for an intervention to support men's engagement and retention in TB care and treatment. Next slide. We conducted this study in Buffalo City Metro Health District in Eastern Cape Province. This cross-sectional qualitative study engaged men who successfully completed their TB treatment and men currently engaged in treatment. Guided by the network individual resource model, we developed a semi-structured interview protocol to explore men's experiences while in TB care as shown amongst these domains. Data were analyzed using a constant comparison approach informed by the NIR model. Next slide. Men described their desire and willingness to support other men during TB treatment with both mental and tangible resources as shown in the following representative quotes. One man specifically said, "I would show them myself as I have walked the same path. It is not easy taking this treatment, but I would show the friend a living example, which is me. I have completed in front of him and pray that I will be a better example to him since I have also come from the same situation. I have swam and crossed, and he also can swim across." Men identified specific tangible and mental resources they could offer to other men with TB, including picking up sputum bottles, role modeling, and food planning. Men believed that other men with a history of TB were key to their own treatment success, since these other men could understand what they were going through while ill, as well as the specific support that they would need during treatment. Next slide. Many men spoke about spaces where they felt comfortable talking about men's issues and suggested that these spaces are conducive to discussing TB. A common theme was that these spaces were primarily dominated by males, as represented in these quotes. One man specifically said, "There, near the community toilets, because that's where you normally find men sitting and playing. You know, even if you come and stop here, and since you know me, my brother, it will be easy to come and start a conversation. A lot of people will listen." Identifying safe spaces for men is a vital step because it is where they socialize, talk to other men, and play games. These participants emphasize that before interventions are implemented, the physical locations where social interactions occur must be understood with invitation from men at those spaces. Next slide. Men reportedly felt isolated from their families and communities during TB treatment and advocated for community awareness to reduce their isolation, as represented in the following quotes. One man said, "And the fact that my girlfriend left me and my mother started to stay with her boyfriend, I really lost focus. I left treatment where I stayed because I was now alone, so I decided to go back on smoking again, and that was my mistake." Men described experiencing rejection and anticipated stigma after diagnosis. This led some men to feel that it was better to skip treatment than to be exposed as someone who could not provide for himself or his dependents. Participants felt that if communities understood and were made aware of the additional challenges TB patients face, they could create a comfortable environment in which men with TB could ask for support from those outside their direct network. Next slide. Men highlighted anticipated and enacted stigma manifesting as embarrassment to seek help and isolation perpetrated by family and community members. Men emphasized the desire for peer-to-peer support in order to navigate TB-related stigma and unhealthy masculinity norms. Men also advocated for awareness events to educate their communities about the challenges men face when ill with TB. Men strongly suggested that interventions be delivered in familiar locations where men congregate. Unfortunately, none of this seems truly groundbreaking. However, no TB support interventions published to date have ever included the preferred components or modes of delivery described by men in our study. Next slide. We recommend that the global TB community effectively engage with men and consider their preferences and voices when designing interventions to improve TB health outcomes. Men must be empowered to challenge their own and society's unhealthy masculinity norms that impact their health. Finally, to decrease the prevailing gender inequities in TB outcomes, men's unique challenges must be identified and addressed, as the current one-size-fits-all approach is clearly not working, and continuing to ignore men's voices will sustain and worsen the epidemic for everyone. Next slide. We are currently conducting 2 large studies. The first is a large mixed method study whereby we will be conducting interviews with 180 men and women. 60 will be TB patients currently engaged in treatment, 60 will be individuals that recently completed treatment, and 60 will be TB patients that exhibit behaviors that put them at risk for being lost from care. These interviews will then inform a discrete choice experiment that will hone in on men's and women's preferences for patient-centered interventions to support engagement and retention in TB care and treatment. The second study will integrate the WisePill electronic medication event monitoring system with a modified ecological momentary assessment to identify real-time or near real-time psychosocial and contextual factors that impact TB medication dosing across the TB treatment cascade. Together, these 2 studies will allow us to understand at a granular level the mental and tangible resources that impact men's engagement and retention in care, with the ultimate aim of developing adaptive interventions to improve both men and women's engagement and retention in TB care, and thus their treatment outcomes. Next slide. Thank you very much.
Thank you very much for that amazing presentation. We really are running out of time and the show must go on. Our last speaker is actually actually talking about the gender disparities, bringing everybody in, ensuring that we've got a gender responsive approach. We now have our next speaker, who is Maureen Marenga. The co-Andrew had so eloquently spoke about the need to integrate men in the TB response. Gender perspective to TB is. Thank you, Maureen.
I will talk to about gender transformative TB response. So first of all, next slide. First of all, I'll talk about TB and gender. And I'll talk about gender being increasingly recognized as a critical dimension for understanding and responding to TB. Globally, we have seen that 64% of new cases occur among males, though in some countries this is reversed. But it reflects on gender patterns in societies and cultures, such as those relating to high-risk occupations, poor health-seeking behavior, and barrier to access. A deeper analysis also shows that there are complex dynamics of risk to access to services. For example, TB in pregnant women living with HIV increases the risk of maternal and infant mortality. We cannot talk about gender without mentioning key and vulnerable populations, which for TB include groups such as prisoners, migrants, refugees, and indigenous population, who often face social marginalization that is compounded by gender. COVID-19 has compounded existing human rights and gender-related barriers, as well as triggered new barriers, which we must identify, monitor, and overcome. A gender transformative approach enables us to be effective and efficient in our investment and to identify and utilize key strategic information in our programming. And through that kind of data analysis and meaningful consultation with affected communities, it is possible for us to know our epidemic and understand our response. Next slide. So I'm representing TB Women, which is a newly formed organization that comprises of women leaders who have been affected by TB from different parts of the continent. And our main mandate is categorized in twofold. The first one is to mobilize and garner collective voice on TB and gender equality, and secondly, act as a global voice on women empowerment and gender transformative TB policy and programming and representation. So TB Women is the new TB and gender responsive watch. We'll be working very closely to watch that programs are gender transformative. Next slide. So in terms of understanding gender and conceptualizing the framework, we will talk about gender transformative TB response, which is built upon the definition of gender as a socially constructed set of norms or roles or behaviors, activities that a certain society attributes that is appropriate for men and women, including the transgender. So we can't talk about gender without also talking about the gender-based prejudice, which includes any kind of stigma, discrimination, violence against somebody, or different treatment against somebody because of their gender identity, or their sexual orientation. Gender transformative programs aim to change these norms and promote relationships between men and women that are fair and just. And gender transformative health promotion, which we are now seeking with TB, focuses on the dual goals of improving health as well as gender equity. It is internationally recognized that gender is among the most influential of the determinants of health, and gender inequities can affect the outcomes and access to health services. Next slide. So if you look at it from an example, if you conceptualize gender, we have gender negative or gender blind programs. These programs fail to acknowledge the different needs or realities of women and men and transgender people, and aggravates or reinforces existing gender equalities and norms. And so an example of that could be a program that doesn't have disaggregated data. And then we have the gender sensitive or gender responsive programs. These ones recognize the roles and contributions of the different people based on their gender, takes these differences into account, and attempts to ensure that women, men, and transgender people equitably benefit from the intervention. An example would be a clinic operation hours that have been changed to early mornings and late evenings to reflect on the needs of working men and women. And then now we have the gender transformative programs. These ones explicitly seek to redefine and transform gender norms and relationship to redress existing inequalities. And such an example would be a program that challenges and changes uneven access to resources in order to strengthen men and women's ability to access TB information and services. Next slide. So gender transformative programming has been supported from the high level, and countries signed into the UN high level meeting on ending TB. And number 18 talks about recognizing the various socio-cultural barriers to tuberculosis prevention, diagnosis, and treatment services, especially for those who are vulnerable or in vulnerable situations, and the need to develop integrated, people-centered, community-based, and gender-responsive health services based on human rights. So that is what the many countries signed to, and which we need to ensure that is happening right from the country level. Next slide. So a gender transformative TB program needs to have the following characteristics. It should be evidence-based. It should be formed on the basis of evidence, and that can only be done if we disaggregate data. It should be equity-oriented, in that we ensure that both male and female are able to access services and the services are designed to their needs. It should be action-oriented, in that once an assessment has been done and milestones of achieving a gender transformative program are put in place, then these actions should be performed to ensure that these milestones are achieved. It should also be focused on the needs of a person, which means it should be person-centered. So we understand that gender needs are different in different environments. So this should be designed according to the needs of the people in that environment. It should also be culturally safe. We have seen programs that are fighting with culture sometimes do not get the desired results. It should be trauma-informed and responsive to the mental needs of the clients. It should also be harm reduction oriented, in that it should not be a program that actually brings a fight between the different genders, but tries to meet the needs of all genders. And then it should be strengths-based. Next slide. So we have seen different tools that help us to move towards a gender transformative TB response. And we have the gender assessment tool for national HIV and TB responses that was developed by UNAIDS and Stop TB Partnership, which is a good tool to develop, to find out the baseline and develop milestones towards achieving a gender responsive programming. We also have TB community rights and gender investment packages by Stop TB Partnership, where an integrated TB community rights and gender assessment toolkit has been developed to document, analyze gender-related services, 20 assessments have been conducted so far, and 5 costed TB CRG action plans have been developed. TB community-led monitoring has been piloted in 14 countries to provide real-time data on human rights and gender-related barriers to services. Then we also have the stigma measurement assessment, TB stigma measurement assessment, now available for countries to utilize and measure and reduce TB stigma and understand relationship available at the Stop TB Partnership, COVID-19 and Gender Toolkit. And the Global Fund has a COVID-19 response mechanism, which is an opportunity to leverage COVID-19 as a strategic opportunity to end TB, and it's called the Deadly Divide Report. There is a need to ensure that gender-sensitive case finding and services, including those for TB and COVID, that there is bi-directional screening and testing, and that way, that kind of integration actually ensures that we implement stronger airborne infection control and implement real-time data surveillance and monitoring of social protections. Actually, COVID revealed to us that we can get daily data, so we don't have an excuse when it comes to data collection. And then countries should also include in their proposal community system strengthening, community-led monitoring, and gender-responsive TB COVID interventions. Thank you.
Thank you very much for that, Maureen. We truly appreciate all of the speakers and all of the wonderful presentations that we've heard so far. I'm going to now do a bit of a Q&A. We've really run out of time, but we've heard such a wealth of knowledge from our speakers. What we're going to be is hand over to the IAA, our colleagues at the IAS, to start the Q&A session. I would like to take my question to Jill before I go. And Jill, that is around the circle versus the cascade of care, and what this says about where we're going in terms of programming, and whether or not we're failing people living with HIV. As you've mentioned, we're looking at a 1 in 3 percentage of people having advanced HIV disease. What is your take on the circle versus the cascade of care? For James Mala, your question is, now that we've seen community participation changing, and we've seen that the role of the community has shifted with task shifting from tuberculosis about community engagement at local levels. What is Stop TB Partnership and partners? What is the plan where the COVID response is concerned? For Dr. Tran, this model that PIFA has been working on around DSD and the fast track mode, whether or not it will be something that will be implemented in COP21, or is this something that PIFA is still planning and refining for COP22? Andrew, unhealthy masculinity norms. That is very important in inclusive gender programming. And you mentioned the issue of familiar spaces and peer-to-peer services around
Hi everyone, I'm just gonna jump in because I think Lynette is losing her audio, unfortunately. Thanks so much, Lynette. Let's start with the questions we had already. Jill, would you like to go first, and do you need me to repeat your question?
No, thank you. I think I've heard the question. Lynette was asking whether I could comment on the Linear, can you hear me?
People away from the healthcare facilities to ensure that we've got limbs of the solution now that we're facing the COVID-19.
Please go ahead, Jill.
Okay, so whether I could comment on the circular versus linear model of HIV care, and I do think we need a paradigm shift there, and we have been failing people with HIV. We need to take into account that people are regularly interrupting care and returning back to care, and in terms of model, there are several things we can do. One, we can start training healthcare staff to welcome people back into care, to also systematically inquire when patients are newly tested HIV positive, whether they are actually patients what we call false naive, who are returning to care but to avoid stigma are pretending they were never on ARVs, and we need to know whether they were on ARVs before, because that will impact which type of treatment regimen or how close we follow them up with regards to viral load. And then I think we do need a paradigm shift towards a much more intensive screening for advanced HIV disease with CD4 and for treatment failure with viral load, so that we prevent so that we start preventing HIV mortality, and also start treating severe opportunistic infections much more aggressively than we've been doing so far.
Thanks so much, Jill. And just another question from Yusuf Bamu. Under the contact tracing investigation, the 17% net increase, if comparing standard of care, what was the contribution of children, and what is the comparison between rural and urban areas in terms of contribution to cases?
Yeah, I think that's a question for Anton.
That was for Anton, okay.
Yeah.
Sorry for the mix-up.
Hi, Terry. I'm back. Can you hear me?
Oh, hi, Lynette. Yes. Please go ahead, Lynette. I'll let you proceed.
Apologies for leaving you all in the church. We have now promote the issue of invisibility.
Right. So Lynette, we were just going to move on to the question for James Maller from Stop TB Partnership, which was the 17% TB yield from the confidence interval data. What was the overall community contribution if this was tracked? Thanks, James. That was from Samuel Kosozi.
I think that in terms of what the role that communities were playing in that, it was highlighting, I suppose, at real time, the impact that was being seen, and we saw that come out in India. So I'd have to get back to you specifically on the percentage that was there, and I'm happy to do that. I can share it with the organisers to feed that back. And the second part of the question, I think, Terry, Lynette had mentioned earlier, which was about the support or the role that Stop TB would play in terms of this going forward. So something that I think is important for participants to be aware, and it was mentioned, I think, in my presentation and also by Maureen, the Global Fund has the C19 RM, which is a particular pot of money, which is very much around the COVID response. Countries have all received their envelopes or their information about how to apply and the sorts of things that can be included there. And so that's something that will begin immediately. So I know that I would just advise people, you know, in particularly in high burden TB and in HIV contexts, to be thinking a little bit about that idea of leveraging TB and HIV responses as part of those broader COVID responses. And I think a lot of the speakers touched on different ideas for how that can be done today. And I'll share again, just in the chat now, one of the guidance documents that can give all the country partners a little bit of information about how best to incorporate that. In addition to that, there are some other funding opportunities like Challenge Facility for Civil Society, which will soon come out. But it is certainly an ongoing piece of work. And from the side of Stop TB, we'll be working closely with a number of other partners, Global Fund, WHO, and many others at the USAID, many at the country level as well, to try to best make use of that particular opportunity that's there and overcome all of the challenges that we know countries are facing. Thanks.
Thanks so much, James. And then for Dr. Tran, there was a question from Ms. Finn Bekela. How do COVID-19, how do people with COVID-19 fare who have TB disease versus are TB free, if there is any difference?
Oh, thanks for that question. I am not a clinician, so I cannot speak on behalf of that. But I'm sure that if you had comorbidities and other health conditions equally, if you had TB or did not, I think that the outcome would be worse. And assuming if you go through that assumption, if you had TB, having COVID may exacerbate your condition. But again, I'm not a clinician, so I can't speak on behalf of that. But there was a question about Dsd integration and whether that would be incorporated. And currently with the CARES funding that I spoke to on my last slide, countries are beginning to implement that in the next few months. We're currently under protocol development to rigorously assess how TB through Dsd models are to see how they perform, because each country is integrating it differently. But within COP planning and COP funding, countries that we support through COP are implementing TB treatment through Dsd models. Again, we just don't have the data from PEPFAR to actually assess it. That's why our CARES funding is supplementing that to conduct that assessment. I hope that answers the question that that one of the guests were asking.
Thank you so much. And then we move on to Andrew Medina Marino from Desmond Tutu. There's a question about where can we integrate men into TB services from their analysis from Desmond Tutu's side. Thanks. From South Africa.
Where to integrate men? Well, first off, my sense from looking at the literature in our work is men have never really been asked their opinions about what interventions would best serve them. And the reason why I make this point is the issue of masculinity definitely impacts men's health behaviors. That's nothing new. The problem with this is that typically men individually and collectively are always blamed for their own poor health outcomes. Now, I feel like that has allowed the health system in the global health community to minimize their own responsibility to respond to the barriers and challenges that men face when they're trying to seek care. So I would somewhat try and turn this around and ask, how does the global health community plan to more fully engage with men around improving men's health?
Thank you very much. I think we just have one quick question for Maureen Morenga, please, from TB Women. How could make a difference between HIV viral rebound and TB on the basis of symptoms? This is a question from one of the participants. And how do we move mental health thinking responses into gender responsiveness? So it's another question.
Yeah, I think talking about HIV viral rebound and TB Usually they're all measured using test for resistance, or when you are on your treatment is ongoing but there's no improvement, then they test for resistance or they test for non-adherence. And I think for both diseases, the viral rebound takes you from one kind of treatment to another. For example, for HIV, you move from first line to second line of treatment, which is a bit more expensive and also has a high pill burden. Same to TB. Those are the similarities, that you are most likely to develop multi-drug resistant strains, and therefore you develop, you get to a more complicated kind of treatment regimen. But both of them are actually issues around non-adherence, which could be due to a magnitude of reasons. For example, sometimes it's lack of information or lack of commodities or other challenges that people face, including stigma and lack of treatment literacy. So I think that kind of approach that looks at the person, their needs, really needs, it's a very important thing when we are addressing both HIV and TB. Thank you.
Thank you so much. And so unfortunately we're out of time, so it just leaves me to thank the speakers, the panelists, and Lynette Mabota for being an excellent moderator. And I'm so sorry that I had to take over right at the end there due to audio challenges. It just leaves me to also thank our funders, the Swiss Agency for Development and Cooperation, and Merck, Sharp, and Dome, who are our donors and have made this webinar possible. We also thank the audience very much for participating and for all the questions, and apologies that we couldn't get to all of those. You will be automatically requested to fill out an evaluation survey when you leave the webinar, so please do that, because it's very important that we get your feedback and continue to improve these webinars. So thank you very much for participating. The webinar has now come to an end, and we'll let you know when the recording is available so that you can watch it again and disseminate it as you like. Wish you a lovely afternoon, day, or evening. Thank you so much.